Professor Dirk Verellen is a medical physicist. He is professor at the Free University of Brussels, and he is also head of physics of the Iridium Kankernetwerk. He was awarded with the Breur Medal from ESTRO a few years ago, and that is one of the biggest honors that you can achieve for your research activities. Next to that, he will be awarded the Emanuel van der Schuren Medal at our spring meeting next year. And this Emanuel van der Schuren was also one of our big lobbyists for radiotherapy in Belgium, in Europe, and internationally. And Dirk will talk about modern radiation oncology, a subtle balance between standardization and individualization. Dirk.
Thank you, Karin, and thank you for the invitation. So I'm switching gears a little bit, but actually it follows very nicely with the previous presentation. What I will be doing is going a little bit more into the details of the technology behind radiotherapy, linking to what Yolanda has just mentioned. One of the questions that we are facing is, it's a subtle balance, as you could call it. You could also call it a tension field in the question on how we are going to develop radiotherapy from a technical point of view. And this balance is between the two questions that you can actually see here. Is this my pointer? Yeah, right. So you have, on one hand, you have the question whether we should standardize our treatments and basically have an automation of our treatments. And if you look at the needs in radiotherapy, you can say this is a good idea because we want to treat more and more patients in a safe way. On the other hand, we have this need to tailor our treatment to the individual personal patient. And then another thing I want to mention very briefly in my presentation is the tension between plug-and-play availability, so that companies give you offer a machine as a sort of a plug-and-play situation, which is not always the case in a very complex environment. So I'd like to give you a few examples of this particular situation. And this all boils down to a very important issue, and this is sort of a bridge to the next presentation during this session, is about safety and quality assurance in radiotherapy. So again, if you see the slides, do we need, so these are two basic questions that I want to answer today, or I'd like to discuss with you. One is, do we need state-of-the-art mainstream equipment, or do we need dedicated equipment for a particular treatment of a particular patient? This is not necessarily the same question as this one. Do we need standardized treatment or an individualized treatment tailored to the particular patient? These two questions are related, but not necessarily the same. So this is why I call this a subtle difference. The bottom line is that, and in this case, I'm going to use stereotactic body radiotherapy, as Yolanda also mentioned, that particular treatment with the collaboration with the KCE, sorry. I'm using, again, also this stereotactic body radiotherapy as an example to show that the bottom line is whatever we choose as a solution here, the bottom line of this particular question, or if you like, this issue, is that SBRT is an effective treatment. So let's focus on SBRT, just as an example. So SBRT is stereotactic body radiotherapy. Typically, we're treating moving tumors inside the patient. So you have motion management here, and there are a lot of variables. The patient is moving from within seconds, within minutes, within days, and within weeks. I won't go into the details. The big problem that we have with radiotherapy is that we don't see the tumor. And I'm using a very nice metaphor from Vincent Grégoire. I'm always using this one, but I like it very much. This is a painting from Magritte, Ceci n'est pas une pipe, and it's in radiotherapy actually a very accurate one, because in radiotherapy it's exactly the same thing. This is not a pipe, this is a painting of a pipe. And in radiotherapy we are treating images of tumors. We are not treating the tumor, we don't see the tumor. So the challenge in radiotherapy is how can we treat a tumor based on images? And so we have, and this brings me then to the basic topic of my presentation, mainstream machines, mainstream state-of-the-art machines, standardized machines versus dedicated machines. These are the mainstream machines that we have today. And you see a lot of imaging equipments on these machines. So there's X-ray images, we can cone beam CTs, and we can try to visualize the internal anatomy of the patient prior or during our treatment. And we use these mainstream machines. So let's bear with me. I'm trying to talk about moving tumors in lung, stereotactic body radiotherapy. We're using these mainstream machines in a way like you can see in this slide. So we try what is called, and typically what people use is the concept of an internal target volume. We try to look on how the tumor is moving inside the patient's body during a breathing cycle. And then we delineate the entire volume where the tumor might be during this breathing cycle. And then we use this information to treat this volume to be sure that we will hit the tumor every day. And so this is how it looks like in practice. We have this ITV, this internal target volume. We take a cone beam CT of the patient on the treatment machine just before the treatment, and we can see that the tumor is not nicely aligned in this volume that we want to treat. Then we move the patient based on the images. We look where the dose will come, and that's my next slide, and then we treat the patient. So that's image-guided radiotherapy using mainstream machines. There's another way. You can have a very dedicated high-technology solution, and then there are two solutions. It's just an example. There are other ones, but this is just one very nice example, I think. You can either use tracking or you can use gating. So it means that in gating solution is that you wait until the tumor is in a certain position in space. So you try to visualize the tumor during the treatment, wait till the tumor is in a certain position, and then treat to that particular position. Or you have a beam that is actually following the tumor all the time. And then you got these very nice, fancy, high dedicated machines. So like, I think this is a movie. Oops, it wasn't hitting. Should be, no, it's not moving. Let's go back. But anyway, it's not so important. You saw high technology machines. And this is basically how it looks like. So this is what is happening inside the patient. You see the dose that is changing inside the anatomy of the patient. So what we did here is we calculated the dose in different breathing cycles of the patient and put it all back into one phase of the breathing so that the anatomy of the patient in this case is not changing, but the dose is changing. You could do it the other way around so that the dose is not changing, but the patient is changing. But you see this very complicated way of treatment. And this is a highly individualized treatment. So what I was talking about is we have these mainstream machines that can actually do the work, or you can have these high dedicated technology solutions. What it boils down to in this particular situation, and I'm using this slide, and this is just a reminder, but it's when I was 16 years old, I bought a very fancy palette to play table tennis. And I was very happy with it, very proud, because I had this very fancy, high dedicated machine. And at a certain moment, one of my uncles, who used to be a champion in table tennis in the province of Antwerp when he was young, he said, oh, let's play a game. And he used the wooden palette. Not fancy. And I shouldn't say this, but basically he beat me with 15-0, 15-0, 15-0. So what I'm trying to say here is that there is not a perfect tool out there. It's how you use it. There is a very nice saying, a fool with a tool is still a fool. And so it's not the machine that does the job, it's how you use the machine. But the main message of what I'm trying to say here is that regardless of the technology that we have, the results are very good, because I was focusing on stereotactic body radiotherapy. This is some results of the latest studies on stereotactic body radiotherapy, and you can see that we have extremely very good 3-year controls and 3-year overall survivals using radiotherapy, not surgery, not chemotherapy. And I'm using a few quotes here. So these are two quotes that I borrowed. So two of Jan van Meerbeek, who is an internationally renowned specialist in lung cancer. You don't have to read everything, but what you have to see here is that SBRT is the preferred treatment, and survival is similar after either surgery or SBRT. Another nice quote here is that in view of its low morbidity and mortality, radiotherapy should be considered the preferred local regional treatment for these particular kind of patients. And I think that's a very strong message for someone that is not coming from the field of radiotherapy. So this is what we can do today with radiotherapy. We have with all these new technologies that we have, we can reduce our margins, and hence we can have less toxicity to the patients. We can create simultaneous integrated boosts. We can review the dose fractionation, so we can try to do things that we wouldn't even think about 10 years ago because it was too toxic. We can have biological conformal radiation therapy, and we can actually adapt our treatment during the course of treatment. And that is basically what is happening today in radiotherapy. So back to the original question. Do we need a mainstream machine or do we need dedicated machines? Again, I hope that the story of the pallets in ping pong in table tennis showed you the answer that basically, it doesn't matter what kind of equipment that you have, you just need to know how to use it. But this is, again, I want to allude a few of the issues that are related to either you use mainstream machines or you use dedicated high technology machines. The question is, in this case, do we need one shoe fits all or do we need a dedicated solution? So do we need a car that can be used for all purposes? Or do we need a highly dedicated machine if we go off-road or a very high-speed car if we go on a track? That's the question. The advantage of standardization, if you have a mainstream machine, it comes with a standardization. The big advantage of standardization is that you have a uniform quality, intra and interdepartmental. So wherever you treat a patient, you always have the same quality, the same standards. So you can swap patients between centers, between machines. You have an easy management of workflows. The quality assurance and the patient task scheduling is all the same. And very important here is that basically you have a standardized care path, and with that comes an increased patient safety. And this is a very important topic, and it will be also the topic of one of the next presentations. And this fits very nicely in the Estrovision, what Yolanda has been mentioning before. The Estrovision is that within Estro, we'd like to have that every cancer patient in Europe will have access to state-of-the-art radiation therapy as part of a multidisciplinary approach, taking into account the individualized specific patient's cancer. That's the Estro view, and actually if you look at standardized automation, this nicely fits into that particular statement. And it also opens the door for big data mining, and it allows for benchmarking because you can compare treatments from different centers. Big caveat here is that this is all within the company users consortium, because with standardization, typically you stick to one particular vendor. A big advantage, and now I'm talking physics, of course, but I think it's a nice example. I'll try to guide you through it. When you're using stereotactic radiosurgery for the brain, we're using very small fields because we're treating very small tumors inside the brain of the patient. And the dose calculation, the measurement of these fields is very complicated. And this is from a company, from Brainlab, the data from different measurements from different centers. And you see that when the field is quite big, so you don't have to read all the details, but this means big fields. Then this is how people measure the output of the machine. And they all agree very well with that. But when you go to smaller fields, you see big variations. So the dose given in this center differs more than 10% from the dose given in that center. And this is because it's very complicated to measure these small fields. And one of the things that was found out by this particular company at a certain moment is that, and this is a report now from in France, people in France at a certain moment in a certain center were using a wrong detector to measure these fields. And they actually measured the output of the machine for these small fields completely wrong. And this was detected by the company because they standardized their treatments. So that's an advantage of standardization. This is another example. If you buy this mainstream machine, the quality assurance comes with the machine because everyone is using the same technology. So people try to get together and try to figure out how they can facilitate the quality assurance, the safety of the patient. So everyone does the same thing, and it's a very nice way. It helps people to actually focus to the real stuff, treating the patient and not focusing on how to figure how to use the machine. It comes with a drawback. The drawback is the fact that it slows down the development. There is lack of competition, there is lack of innovation, there is lack of creation. And a very nice example is, for instance, tomotherapy. I won't go into the details of the machine, but this is a development that was done in the early 90s of the previous century. And everyone was talking about intensity-modulated radiotherapy, a new way of treating patients. But everyone was talking about it, nobody was doing it, except in a few academic centers. And then came this company with a new approach, which was tomotherapy. And suddenly IMRT became clinically available, and suddenly the other companies woke up and actually made sure that IMRT was available also on these mainstream machines. So you need these developments, you need this creativity to actually drive the field. Another example is individualization. Do we need standardized treatments of the patients, or do we need individualized treatment? This is the second question in my introduction, basically. And again, I'm using an example from a company. It's not important which company it is. But one of the things that you see more and more is that people offer templates. A standard treatment for, in this case, multiple metastases in the brain. It's just one push-button solution to treat multiple metastases in the brain. It looks very nice because it's a template-based, standardized treatment. All the patients will have the same quality of treatment. It looks appealing. It comes again with a drawback. Because more and more what we see in radiotherapy today is, for instance, this is again an example, but what we see more and more is that people come for a re-irradiation. So that people have been treated in the past, they live long enough, quality of life is good, and they come back with a secondary tumor, with a metastasis or whatever. And we see more and more patients coming back with re-irradiation. And there is no standard for that. So you need to individualize that treatment. And so this is just one example from my previous clinic, where we were treating a patient for esophageal cancer, and the patient later came back with a metastasis in the cervical spine, abutting to the original treatment. And so you can't treat this with a standardized template-based approach. And then a last point is basically the black box phenomenon. And I'm using, you all know the problem with VW and Opel and the problems that we have seen with the engines and pollution. This is exactly the same thing you can say in radiotherapy. I mentioned before that it's easy to standardize the quality assurance if you go to a mainstream solution. On the other hand, it comes with a drawback because the quality assurance, the testing of the machine is also part of the actual equipment. And this has then the danger of VW, basically, that you're using the equipment itself to test the equipment. And so you need some kind of an objective way of making sure that the machine is actually working. And this is then a more individualized approach of making sure that this machine is doing what it's supposed to be doing. And so this black box phenomena is also a danger that we have to take into account. So a short conclusion. I don't know how much time I have left. 10 more minutes, okay. A short sort of a sub-conclusion, if you'd like, intermediate conclusion, is that whether we have standardization and automation or individualization, I hope that with the previous slides I gave you a sort of a technical insight in radiotherapy. But the main message I'd like to make here is that radiotherapy is a very highly dynamic and evolving discipline. And it's crucial, as has been mentioned before by Jolande and Steven, it's crucial for the treatment of cancer, and it features different specialties, each with their own typical application. So what I'm trying to say here is that we have external beam and brachytherapy radiotherapy. We have photons, we have electrons, we have protons that are looking behind the corner, and there are other particles that are being mentioned more and more. Important in all this is that whatever tool, whatever palette that we're using to treat the patient, it's how we use it. The key is image guidance. And very important in this entire story is the fact of safety and basically the quality of the treatments. And I've mentioned it a few times in my previous slides, but the aim of radiotherapy can only be realized if we know that the correct tissue will be treated in the correct patient with the correct dose. And I hope that with the previous slides I've shown you, and these are just a few examples, is that all this has to be accomplished in one of the most complex settings in healthcare. And so it becomes quite complicated if you want to manage all this. So this brings me to risk analysis, and which is a very important issue in radiotherapy, and the next speaker will focus on that much more than I will be doing, so this is sort of a bridge to that particular presentation. But you need to realize that radiotherapy is probably one of the medical disciplines that is most watched by the media because it's about ionizing radiation. It's very sexy when something goes wrong in radiotherapy. But nevertheless, you need to realize that the developments of radiation protection standards are very well established. And it goes back immediately to the discovery of radiation therapy. New developments in radiobiology by default require that we know the delivered dose to the patient. Patients also require that they have access to what was really delivered to the patient, not what we plan to give them, but what was really delivered. And this is embedded in the radiotherapy approach. We want to know what dose was exactly given, and by default, this means that we know what we're doing. We try to know what we're doing, and quality assurance is a very important aspect of radiotherapy, and it's embedded in the procedure. And just to give you an example, is that we have this philosophy in radiotherapy of risk assessment and quality assurance. And these are just a few examples of what's happening in the world, in Europe, but also in Belgium. We have these risk analysis groups and projects all the time. So we have the Prisma RT and the BELDART, which are quality audits in Belgium to make sure that radiotherapy is treated in the right way. And this has been done not because it's an interesting topic today at this particular moment, but it has been done throughout the centuries from the beginning of radiotherapy. And for instance, now at ESTRO also there is this particular safety committee. And just to give you an example, these are reports, they're already quite old, but again to show you that quality assurance and safety in radiotherapy are embedded in the process from its start. So quality has always been a major issue in radiotherapy. And this brings me then to the last question. Mainstream machines, dedicated individualized machines, it comes with a cost. And Yolanda mentioned it in her previous presentation also. What is the cost of this? I'm looking at this from a very, very philosophical point of view. For me, the true cost of something is what you are giving up to acquire something. And the main question that we should ask ourselves when we talk about radiotherapy on a Belgian scale or on a European scale is if we have a new expensive technology and it comes at the cost of reducing the healthcare for the average cancer patient, so that we have a very dedicated, high-tech, very expensive machine for a few patients, but because of that we cannot treat the majority of the patients the way we want, then this is a very expensive machine. It's a question that we have to ask ourselves. And just to give you an example, society pays, of course. Prostate is a very nice example. When you look at prostate, there are different options for the patient. And sometimes it might be very confusing for the patient. You can perform watchful waiting, just wait a little bit and see what happens with the tumor. There is androgen deprivation. There is HIFU, there is prostatectomy using a Da Vinci robot, which is very expensive if you'd like. There is a 3D conformal radiotherapy, there is IMRT, there is stereotactic body radiotherapy, there are protons, and there is carbon. And all these things are treating the prostate basically with the same results. And so the question is, what are we willing to pay or to give up for this particular situation or for this particular patient? And the most obscene or perverse thing that happens with these situations is that if a patient is given the option for a treatment for a certain tumor, and there are two options, one is 3,000 euro and the other is 30,000 euro, surely the patient will think that the most expensive one is the most efficient one. And this is not always the case. So we have to be very careful for that. We have to both educate the policymakers and the patients and the population to make sure that we are using the right treatments for the right patients. And the problem is, of course, that the internet is feeding this option. Companies are putting this on the internet and it looks for a patient that this very fancy, expensive equipment is what they actually need. So, brings me to my conclusions. I try to give you an overview of some of the technology challenges, if you'd like, of radiotherapy. Trying to focus on whether we should have mainstream machines or dedicated, whether we should standardize the treatment or whether we should individualize the treatment for the patient. This is a very subtle balance. It's a sort of a tension field, but it shouldn't be that much of a tension field. It's really a subtle balance. So rather to force the user to adapt to a new technology, so rather to force the patient or the centers to adapt to a new technology, we basically should allow a personalized treatment tailored to the individualized patient. And the only way we can do this is that we have, so the key to unlock this dilemma is that we have an open communication, a close collaboration with the policymakers, with the companies, and with the radiotherapy departments. And that will help us to drive the developments in the right way. And again, I'd like to end with the ESTRO vision, what we strive for. And this is the ESTRO vision, so this is on the European level, but I think we can translate, I hope we can translate this to the Belgian level, is that we should strive for a situation where every cancer patient will have access to state-of-the-art radiation therapy. This does not mean a high-tech dedicated machine necessarily. It could be, but it's not necessary. But what is important, and I think this is very important, is that it should be tailored to the individualized patient. And standardized treatments can help in having a high-quality treatment for a majority of your patients in a safe way, but it also has to allow some kind of individualization. And if this is happening, and this could be done with mainstream machines, this could be done with dedicated machines, then I think we reach our goal. And I think with this, I'd like to stop.